Hi everybody, I'm Adam Hoffberg, and thanks for joining us for the Rocky Mountain MIRECC Short Takes on Suicide Prevention podcast. For this episode, we'll be chatting with Dr. Meredith Mealer. Dr. Mealer is a researcher at the Rocky Mountain MIRECC and assistant professor with the Department of Physical Medicine and Rehabilitation over at the University of Colorado Anschutz Medical Campus. And today we're going to be learning more about resilience, burnout, and PTSD among providers. And thanks for joining us, Meredith.
Thanks for having me.
Great. So, as we always do, let's start off with just a little bit of background on yourself, an introduction, and really how you got into this line of research.
Sure. So, I have been here at the University of Colorado for about 10 years. Before that, I was at Emory University in Atlanta, Georgia. I started off as an intensive care unit nurse, which is why this is interesting to me. First started looking at the prevalence of post-traumatic stress disorder, anxiety, and depression in ICU nurses because I was seeing those ICU nurses leaving the bedside, and I would ask them, why are you leaving? Why can't you stay? And they would tell me, I was having nightmares, or I'm really anxious, and I just can't be in the ICU anymore. So that made me think, hey, what's going on here, and why are we losing all these good nurses? So that kind of pushed me in the direction of the psychological health of critical care healthcare providers.
Thank you for explaining that. I didn't know that you were an ICU nurse in the past, so that's, as we talk more about your research, it makes a lot of sense that this is the population you're working with. Also makes sense that these are very challenging work environments, and these nurses are caring for very difficult cases, challenging. Let's now talk about what you found out about the PTSD and burnout among these providers. Can you tell us a little bit about your work in that area?
Sure. I've done 3 sort of prevalence studies. One was done at Emory University and involved the Emory University affiliated hospitals, so similar to the University of Colorado system. And then I moved out to Colorado in 2006 and replicated that study at the University of Colorado, not only in ICU nurses, but also in all the different specialties in the hospital. I also included the Children's Hospital to see if there's a difference between adult and pediatric healthcare providers. And then, based on the results of those 2 studies, I did a national sample to see if this could be generalizable, which I thought it would be, but of course we needed to get that data to support that. So what we found was really interesting because it was across the board pretty much the same prevalence rates. So we were seeing a prevalence of PTSD symptoms in about 25 to 28% of ICU nurses. And if you're aware, 8 to 10% of the general population at some time in their lifetime experience a traumatic event and have PTSD symptoms. So this is way above what you would see in the general population, and it's also similar to what we're seeing with those returning from the war in Afghanistan and Iraq. So the prevalence of the symptoms were anywhere between 25 and 28%. We added a diagnostic tool, which is called the Post-Traumatic Diagnostic Scale. It includes all the elements to meet the DSM-5 criteria for a diagnosis of PTSD. And the prevalence of a diagnosis was about 21 to 22%, again, very high. Anxiety was high across the board, so we were seeing anxiety levels anywhere between 60 and 80%. And then depression kind of fluctuated, and it fluctuated by region. So the prevalence of depression in the South was a little higher than it was here in Colorado. And nationally, it was kind of in between there. So what we found was that it was prevalent, it was a common problem in these ICU healthcare professionals, and something that I wanted to work with and try to find interventions to help mitigate some of those symptoms.
So help me understand PTSD among these ICU nurses or other providers a little bit more. Is this the same PTSD as our soldiers are experiencing after a war event, or break that down for us, please?
Sure. So there are 2 different types of traumatic events that can lend itself or trigger PTSD. One is direct exposure to a traumatic event, and the other is an indirect exposure. For our soldiers who are at war that are experiencing bomb blasts or getting shot, what have you, those are direct events. It's happening to their person. Whereas an indirect exposure to a traumatic event is or involves witnessing someone die or witnessing something bad happening to someone else. And again, it's the same response is that they respond to that traumatic event with fear, helplessness, and horror. That's the same between the direct and indirect. It's just the actual experience is a little different.
I see. And we can imagine that our ICU nurses are indirectly experiencing many traumatic events with patients at serious injuries and critical condition.
Absolutely. I mean, it's a cumulative exposure. It's something that they're involved with 12 hours a day, sometimes 3 or 4 days a week. These patients can be very sick on life support. They can be bleeding. They could be terminal patients where the nurses are grappling with whether they're actually providing care or doing harm to that patient, trying to keep them alive. So I think those experiences are quite traumatic for them.
Mm-hmm. That's very helpful. Obviously, we want to do something about it or help bolster resiliency. And what is resiliency?
Well, in the simplest form, resiliency is the ability to bounce back after adversity. So there's kind of a couple different schools of thought. Some people think that resilience is an innate characteristic, but then others think that it's a modifiable or a behavioral characteristic that can be learned. And so that's what I'm building my research off of, is that it's a modifiable characteristic and it can be learned.
Okay, so tell us some of your next steps in terms of work that you've done to pursue this psychological resilience training.
Sure. So as part of the national prevalence study that I did, there was a quantitative and a qualitative piece to it. So the quantitative was just looking at what the prevalence was of these disorders and then how resilience maybe mitigated some of those symptoms. The second piece was the qualitative piece, where I divided the sample into 2 cohorts. So one, those who had or met the diagnostic criteria for PTSD, and those who scored as highly resilient on the resilience scale. And I interviewed both groups. And what I wanted to know is, what is it that keeps you at the bedside in the resilient group? What coping mechanisms do you use so that you can go back every day? And how do you recharge or refuel? The same questions I asked the PTSD group, and what I found was that they were hugely different, the coping mechanism. The PTSD group tended to cling on to maladaptive coping mechanisms, whereas the resilient group had very good resilient coping mechanisms. So based on that information that I learned from those highly resilient nurses, I developed pilot intervention. So in my intervention, I used those coping mechanisms that those nurses described.
Okay, and can you tell us a little bit more about what were some of those coping mechanisms?
Sure. I conducted a pilot study, a pilot resilience intervention. It was a randomized controlled trial. Very small, 13 subjects were in the intervention group and 14 were in the control group. And for the intervention, these nurses came in and they had a 2-day seminar where we introduced the concept of resilience. We also introduced each of the interventions that they would be exposed to over a 12-week period of time. And so those interventions were written exposure therapy. So there's a lot of literature, not a lot, but there is literature about using writing or journaling for post-traumatic stress disorder. It's similar to exposure therapy in that you're having a patient talk or write about their traumatic event.
Okay.
So that was one. We had event-triggered counseling or cognitive behavioral therapy. So similar to what you see in the police law enforcement field. So if police officer shot someone, they would have to go to a mandatory counseling session, took the stigma away from who actually needed to go and get help and who didn't. So we used this event-triggered counseling session model and had specific criteria outlined. So if your patient died, if you performed CPR, if you had a patient with massive traumatic injuries, things like that, they would go and have a session with one of our counselors. So that was a second intervention. The third was exercise. So in Colorado, that's not hard. A lot of people do exercise, but we had them do at least 30 minutes of aerobic exercise 3 times a week. Mm-hmm. And we protocolized what that meant. So we listed some options that they could choose from. Since, again, we are in Colorado and people tend to exercise, we also had the control group just write down how much they exercised just to see if there was a difference based on the intervention. Mm-hmm. And then finally was mindfulness-based stress reduction. So during that 2-day seminar, we had someone from the Center of Courageous Living come in and walk through sitting meditation and the body scan. Those were 2 of the MBSR techniques that we used. And then they were given guided CDs that they took home with them, and they were asked to perform MBSR activities for 15 to 20 minutes 3 times a week. So that was the intervention. Quite complex. And again, this was a pilot study. We just wanted to see, is it feasible and is it acceptable to the nurses? And what we found is, number one, yes, it was feasible. We had a completion rate of anywhere from 89 to 100% with those activities. And it was acceptable. We sent out some satisfaction surveys on each of the interventions. They were completely satisfied. They didn't think it was too much of a time consumer. They were excited that we were doing something to help the helpers. We had fantastic results.
Talk to me a little bit more about this multimodal aspect of it and why that's a strength of the intervention.
So I still feel that that's a huge strength. The reason is that everyone's an individual and everyone has likes and dislikes. So if I only did an intervention that included writing, you may not like writing, and I love writing. The idea behind multimodal was that we could reach as many of these nurses as possible and at least give them something that could provide relief from these symptoms.
This expressive writing concept, I think, was also actually new to me and maybe to some of our listeners as well. Could you tell us a little bit more about what that involved?
Sure. So written exposure therapy is essentially where you expose a person to the trauma through writing. So there are traumatic events in the work environment, so we picked some writing prompts. We gave choices of 3 different types of prompts that they could write on for that week, and they were asked for 30 minutes to write about that trauma. And then we had integrative health coaches that would read those writing examples and would provide some feedback of, please explore this piece a little bit more. Tell me more about this. Maybe put some reframing and flexibility in there to help them when they experience something like that in the future.
That sounds great. How was all this data collected for your study?
Yeah, so I think that was what was truly unique about the study is we wanted to be cognizant of the fact that this was sensitive information. We worked with these people, being my co-investigator and I both are in and out of the ICU. We didn't want them to feel worried about what they were writing. And that we would see them in the hallway and say, oh, you only did half of your exercise, or we looked at them differently because they were struggling and someone else wasn't. So what we did is we used an honest broker. An honest broker is someone who is not affiliated with the study. You typically have to pay an honest broker. And what they essentially do is de-identify your data for you. So when these nurses signed a consent form, I sent the consent form over to the honest broker, and she assigned a study ID. She was the only one that had that link between the name and the study ID. We then created a REDCap database, and when the participant went into the REDCap database, they only used their study ID. So there was no PHI identifiers in that database, so that when I went in and looked at it, it was completely de-identified. And that, of course, it secures the data. REDCap's a secure, encrypted database environment to begin with, which is great, but it also completely de-identified it in case there was a way of putting the names back with the study IDs, since this was sensitive and potentially stigmatizing information.
As you mentioned, the results from this initial trial was positive. It was acceptable, it was feasible. And so what are next steps from here?
It was acceptable and feasible. That was the goal, but we did, of course, look at some of the statistics. So did this intervention decrease PTSD diagnoses, anxiety, depression? Did it increase resilience? This was a resilience intervention. So at entry, none of these nurses could be resilient based on the CD risk, which is the Connor-Davidson resilience scale. Based on the original work of that instrument, a score of above 82 is considered resilient, and then one standard deviation above that, so a score of greater than 92 is considered highly resilient. So we didn't want people to already have resilience. So these were people who weren't resilient that were entered into the study. So what we found is that in the intervention group, the intervention decreased PTSD and depression and anxiety, and increased resilience. But what was interesting is that in the control group, resilience scores also increased. PTSD scores didn't decrease, nor did depression and anxiety decreased. Okay? So why did that happen? This was a control group, and we did nothing for this group other than consent them and asked them to write down how much exercise they did. And they filled out some of our baseline surveys, okay?
Right.
What I think happened is there was some type of treatment contamination along the way. Could have happened a couple different ways. One, these were nurses who all worked in the same hospital, maybe even the same unit together. So you could have two that were in the intervention and one that was in the control group working on the same shift. So that's one reason. They could have talked about it, even though we asked them not to talk about it. They were all excited, so I'm sure they did share some of that. And the other is the consent form. So in the consent form, we described exactly what the intervention was going to be, and they could have seen that and said, hey, I think I'm going to start exercising more, or I think I'll start journaling. So we're not sure why that happened, but I think if we, moving forward with future research, we really need to be mindful of this treatment contamination concept. So what we've done is I just recently got an R34 funded for a larger controlled trial for a resilience intervention in ICU nurses. So as part of the design of the study, we will do a stepped, wedged, clustered randomization. And that will hopefully eliminate some of that treatment contamination.
And thank you. So stepped wedge cluster randomization. And I know that we have some folks listening that may be more on the clinical side or even researchers who may not be as familiar with that study design. And I'm really curious what that involves.
Sure. So the pilot study was just at the university hospital, so there wasn't much that we could do there. But with this R34, we've got about 9 different hospitals in the Denver metro area that are participating. So the cluster is the hospital. So they're going to be randomized by the hospital. They're all going to be randomized to the intervention. The stepped wedge piece of it allows hospitals to serve as their own controls. So the intervention is 5 months long. So hospital 1 will be getting an intervention for 5 months, while hospitals 2 through 9 are serving as controls for themselves. We'll be asking these different psychological measures. When the 5-month intervention is over with Hospital 1, Hospital 2 will start the intervention. And then we'll be able to start collecting post-survey responses, treatment effect responses on the hospitals that have already been through the intervention. So that's the stepped wedge piece. So the good thing about stepped wedge is they all get the intervention, and they all get portions of the control, so that you don't have to have a bigger study to actually study a control group too.
Wow, that's great. We certainly look forward to hearing how long is this study going to take to get all 10 hospitals through the intervention.
It's a 3-year study. The first year, we've got some focus groups to better design the actual rolling out of the intervention, so feasibility issues. And then the second and third year will be the clinical trial, getting the nurses recruited, and then randomizing them into their cohorts.
As you mentioned, you're still researching this, still have a lot to learn, but from what we know so far, what sort of advice or recommendations could you give to, providers that are maybe in the ICU, but maybe just providers that are in mental health or anywhere else for that matter, that have a stressful work environment, and, what are some skills or coping mechanisms that they can start to use?
I think as a whole, healthcare providers tend to take care of themselves last. when they should be putting themselves first so that they can be the best that they can be at the bedside with their patient. I think recognizing that you're having issues with your environment is important. And then once you've recognized that, either self-employing some of these coping mechanisms or actually getting professional help to deal with some of the issues that may be coming up. So, I think exercise is good. I think mindfulness is a great activity that you don't need to pay admission or membership fees for and things like that. So it's a fairly inexpensive thing that you could do at any point in your day. If you like journaling, I think journaling, of course, could be helpful. So there are a wide variety of coping mechanisms that healthcare providers can use without getting outside help from mental health care providers.
Mm-hmm. Well, thank you. This has been really interesting. And just any sort of final thoughts for today?
So my final thought is that even though this is in the ICU nursing population, resilience is something that everyone could benefit from. So I think this can be extrapolated to many different populations. And so my hope is to start to explore this in different groups. So ICU physicians, mental health care providers with the same trajectory that I did with the ICU nurses and hopefully bring some resilient measures into their careers as well.
Fantastic. Well, everybody, we appreciate you for listening, and you can learn more about Dr. Mealer and her work by looking and clicking at some of the links accompanying the podcast. Don't forget to reach out to us if you have any comments or questions about Meredith's work. And also, please take a moment to subscribe to the podcast and rate it and share it with your colleagues. Until next time, this has been the Short Takes on Suicide Prevention podcast.